and Keren Gadasi. Hello, Keren.
Hello, good evening.
Hello, welcome. And let me again introduce you and your title, please. You're gonna present a silent cry for connection and bridging the gap between high stakes decision making and deep empathy in birth spaces. Lovely. And let me explain about yourself a little bit, and I will give you the stage. Keren Friedman-Gedasi is the founder of the B.O.T, which means birth-oriented thinking approach, developed to improve communication in professional birth settings, particularly labor room in Israel. She has trained hundreds of professionals and is a leader in addressing complex communication challenges in maternity care. With intensive experience supporting women and couples affected by loss, miscarriage, and birth trauma. Keren promotes collaboration between labor teams and mental health professionals. The B.O.T approach presented globally offers tools for dealing with secondary trauma in caregiving teams and is now used to train doulas, lactation consultants, pelvic floor therapists, and others in the birth field. Welcome, my dear, and this is your time now.
Oh, hello. I'm truly excited to be here. You're doing here such an important work. It is inspiring to hear the rich variety of speakers. So to begin, I want to take you back with me. I'm from Israel. To a warm Israeli summer evening back in 2001. I was young, both in age and experience. That evening, a pregnant couple came to my small studio in the village where I live for a childbirth preparation session. They were beautiful, the kind of beauty that makes you instantly like someone. They sat close together, holding hands almost the entire time. At one point, I was explaining about some medical intervention that might come up during birth. And then she suddenly asked, can they, meaning medical staff, do something to me without me knowing? I answered, I tried to reassure her, but then she asked again, in different words, how will I know what's being done to me? Can someone force me to do something I don't agree to? And somehow, despite of my lack of experience, I paused. And I said, it sounds like something here is really worrying you. Do you know what it is? I was not prepared for what followed. She began telling, for the first time, about long-term abuse she experienced in childhood. She had never told anyone, not even the man sitting next to her, holding her hand. There we were, she whispering a story that had never been told. He, hearing it for the first time, trying just to keep breathing. And me, sitting with them, with no training, no words, no tools. Just a deep ache in my jaw from the fear of saying the wrong thing. So looking back, I can say that that moment was the beginning of a long journey. So when you presented me, you said that I'm the founder of a B.O.T organization, which stands for Birth-Oriented Thinking. And when people ask me how the B.O.T. was developed, I usually say, it took over a decade and hundreds of real-life moments that stayed with us. So for more than 10 years, me and my colleagues, we documented encounters from the birth field. Sessions with women and couples, both formal and informal. For example, a woman that came to prepare emotionally for an upcoming amniocentesis because of her needle phobia. Or a couple who came because both were carrying difficult memories from past hospitalizations due to his combat injury. Or a phone call from a pregnant woman to her doula a few weeks before the birth, saying, I think I don't want him in the delivery room. I'd rather he stayed outside. What does that mean to our relationship? She whispered. Or a call from the husband 4 days after stillbirth, saying she's not able to speak, but her milk is coming out and she's in so much pain. We are lost. Can you tell me what to do? So we started documenting these conversations because we felt a gap. Situations that childbirth professionals were encountering again and again with good intentions and good intuition, but often without the tools to respond effectively. And we also noticed the impact left on those caregivers, the emotional weight that had nowhere to go. B.O.T. was born from this space, from the questions we didn't yet know how to answer, and the stories we couldn't forget. And for the past 12 years, we have been offering knowledge and training to hundreds of professionals in Israel from various fields such as OBGYNs, nurses and midwives, healthcare providers, psychotherapists, birth workers, lactation consultants, yoga teachers and doulas, Jewish and Arab. And here are the problems we face. On one hand, research has shown that poor communication in maternity care is a major contributor to stress, anxiety, and post-trauma. We know that. On the other hand, those interactions often happen to take place in short-term appointments, sometimes without prior familiarity with a patient, or in a high-pressure environment with not much room for emotional care. And many professionals feel unequipped to address these challenges, yet the emotional needs of patients remain. So how do we bridge this gap? So at the B.O.T, we have developed a structural, practical framework for integrating emotional awareness into routine maternity care. This is our focus. But in our training, we begin to address that from the inside with this core internal question. What is happening to me as a professional within the situation? Our premise is that this is the starting point that enables real change. We call it point zero. So instead of trying to teach how one should speak or express empathy, we teach inner steps for developing sensitivity to the nuances of the sensual and emotional experience of oneself as meaningful indicators for communication. So the learning in B.O.T. takes place first and foremost within ourselves as professionals. Only through this inner awareness can the skill be developed for use in communication with patients. The dual model that guides the training is based on simultaneous attention to two layers. Interpersonal communication with the woman in labor, the patient, the client, the couple. Intrapersonal communication with the internal experience occurring within me as a caregiver during the encounter as a compass that can guide the interaction. Let me share a real story with you. A midwife I worked with told me about the time she supported a woman through stillbirth. She stayed by her side, guided her through the birth, and held space for her grief. And when her shift ended, she walked out of the hospital and sat in her car for over an hour, unable to move, unable to cry, unable to process what had just happened. The next day, she went back to work. No debrief, no support, just another shift. She told me, I don't know how much longer I can do this. And she's not alone. We know that. Many professionals struggle with feelings of helplessness when witnessing loss and trauma. Caregivers and birth workers are at high risk for burnout and secondary trauma. And institutional support is often lacking, and emotional challenges are seen as something we should just handle on our own. But ignoring this reality doesn't make it go away. We know that. And the ripple effect of loss and trauma doesn't stop at the mother. It extends to the professional who care for her. And here's the truth. We, as professionals, are taught to be compassionate, to be present, to be supportive. But what happens when that very compassion becomes the things that drains us? And this is the empathy paradox. On one hand, we want to connect. We chose this profession because of the profound potential for deep connection. We know that empathy is at the heart of good care. But on the other hand, we also experience when too much emotional connection can lead to burnout and compassion fatigue. If we detach too much, we lose the human connection that defines our work. If we engage too much, we risk emotional exhaustion. So how do we navigate this? How do we provide deep, meaningful support to the people we care for without losing ourselves in the process? I want to demonstrate an option through an example told by a midwife who graduated from the B.O.T training, and this is what she wrote. A colleague of mine, that was she wrote, a colleague of mine attended what started as a completely normal birth, but it ended with a devastating perineal tear. She blamed herself, even though there was absolutely no reason to. But from that moment on, during every shift in that week, she asked to work in the maternity triage area, trying to avoid being in a position where she would have to attend a birth. I worked with her just like we learned, giving space for the emotions, letting her express what she hadn't been able to express at the time. Every shift we worked together that week, we took 5 minutes to focus, and each time I asked her 3 questions about the moment of the tear. What are you feeling now after it all? What would have helped you when it happened? And what do you need right now? Each time, tears welled up, her throat tightened, and we stayed there for a while. A week later, I asked her how she was doing. She said, "My smile came back, and so did my hands." So this is the heart of the B.O.T communication, creating space for emotional processing in real time, not only for the birthing woman or for the birthing person, but for the caregivers as well. So before I end my talk, I want to say that we need a fundamental shift in how we define professionalism in maternity care. Professionalism is not just about clinical efficiency. It is also about how we communicate, how we hold space, and how we support both patients and each other. And this is the change we must work towards. And it starts with each of us. Thank you.
Thank you, Keren. Thank you so much. I think we are full of tears while we are listening to you. Thank you. It really touched my heart personally. And
thank you. I'm very touched to be here. It's very inspiring.
Thank you so much. Well, actually, we have time. If we have some questions or let me see about the chat. Oh, everybody loves your presentation.
Okay. Thank
Very
you.
important, touching, and thank you so much. Very beautiful.
Thank you. I saw the question is the classes are taught in English, not yet. And Jenny is here, Jenny Kozlo, which I'm here because we met sometime long ago, and she's always asking me about, classes and sessions in English. So we are working on it.
Okay. Well, this is the start, at least.
This is a start. This is a start. Yeah.
Oh, why not? Maybe we learn Hebrew. Why not?
It will be easy for me to do classes in English. Thank you. Thank you.
I also train midwives, doulas, and doctors, and I'm a birth psychologist. And personally, I also value about the personal work, and especially secondary trauma,
Yeah.
and how we witness what is going on, and how we are helpless sometimes, or speechless, and we cannot do something in front of our eyes. So this is a very big work, actually, and it's also very hard.
Yes. Yeah.
Maybe if you can give any kind of very small example that it's really working on you, especially because I can see you are also a caregiver for the caregivers.
Yeah. Mm-hmm.
The kind of a togetherness and to help to each other. So what is the most important tool or key for especially for us taking care of the for caregivers or birth teams? What is your, I mean, I know it's a big subject, but as a summary, what can you share with us right now?
There is a model that we work with of partnership, of collegial partnership. And so midwives and doulas and physiotherapists and lactation consultant and yoga therapists, we do partnerships for each other, which means we call each other at times we need. Okay, and it's not just to call you and to tell you how much traumatized I am from what I've seen or heard. It's to tell you what's going on inside me right now, and you know, because you learned this language of partnership, you know how to be with me and ask me some questions that I can explore what is happening to me right now, okay? And then most of the times I can really understand something new in myself, okay? So it's not just to, like, you know, discharging, okay? It's developing. Okay.
Perfect. It's kind of exploring, actually.
Yeah.
Love. Yeah.
Yeah.
It's kind of a peer supervision, and
Yeah, kind of a peer supervision. We also like to call it undervision.
undervision. Yes.
Okay. Okay. So because when you call me, so I'm like, you know, I'm not superior. I'm you know, I like understand. So I'm
So it's peer.
yeah.
Together.
Yeah.
Thank you.
Okay.